So we've got clinical case. Let's go. Take your pens, papers, and let's go. 80, a year-old lady with a long history of type 2 diabetes, well controlled on metformin, is admitted to the hospital with specific shock from a urinary tract infection. She is hypotensive and has an acute kidney injury. So with a serum creatinine of 3.5 milligram deciliter, her baseline 1.2 milligram deciliter. Hola. In these clinical settings, the patient is at highest risk for developing which specific life-threatening complication of metformin therapy? Good, but tricky question. Okay, give me options. Hypoglycemia. No. Next, pancreatitis. No. Lactic acidosis, that's it. And vitamin B12 deficiency, of course, lactic acidosis, option C. Why? So this question asks the student to identify the most critical and acute adverse effect of metformin in a patient with precipitating factors. Yes, what are they? So lactic acidosis, yes, lactic acidosis, this is a correct option. Metformin-associated lactic acidosis, so-called MALA, MALA, is the most feared, yes, though rare, but complication of metformin. MALA, it's metformin-associated lactic acidosis, abbreviation, of course. So metformin's primary action is to inhibit in mitochondrial enzyme complex, which decrease glucose production in the liver. A side effect of this is a slight increase in the conversion of glucose to lactate in the gut. So, in the role of the kidneys. In a healthy person, the kidney easily clears this small excess of lactate with no problem. But this is a perfect storm. This patient has a perfect storm of what? Of risk factors. She has a septic shock, which itself causes severe tissue hypoxia and massive lactic acid production. On top of that, she has an acute kidney injury, right? Meaning she cannot clear either the lactate from the sepsis or the metformin itself. So neither this, either the lactate from the sepsis or the metformin itself. So the accumulation of metformin to toxic level of severity inhibits the body's ability to process lactate, leading to a profound, life-threatening lactic acidosis. This is why metformin is absolutely contraindicated in patients with severe renal impairment or acute circulatory shock. Okay, my beloveds. So why the other options are incorrect? Okay, let's answer. Hypoglycemia. Unlike many other diabetes drugs, like for example insulin or sulfonylureas, metformin is euglycemic. It doesn't actively lower blood glucose. It primarily prevents it from rising. No, okay. So in very rare causes hypoglycemia when used as a monotherapy. They say that. So hypoglycemia anyway is not likely at all. Pancreatitis. Why pancreatitis? Well, some diabetes drugs like GLP-1 agonists have a debated association with pancreatitis. Metformin is not a classical cause. Classic cause not all. Vitamin B12 deficiency. This is well-known chronic side effect of long-term metformin use, as can interfere with B12 absorption in the gut. However, it's not an acute life-threatening complication that would be the primary concern in a patient with septic shock. Okay? So what is high-yield takeaway, my beloveds? The single most important contraindication to metformin to severe renal dysfunction. The single most important contraindication to metformin use in a severe renal dysfunction. Underline it. So in any clinical scenario that causes acute kidney injury or severe tissue hypoxia, like shock or severe heart failure, metformin must be held to prevent the development of life-threatening lactic acidosis. Understand? Great. Stay blessed.